Testing. All right. Can you hear me okay? The microphone doesn't work. And I can't see you because this light's in my face. So thank you, Mukta. That was wonderful. I think you should have done the entire thing. You don't need to hear from me. So I think the transition here is quite good because Mukta talked about a specific example of health promotion and health communication. And I'm going to talk big picture, some of the underlying theory of health communication and health marketing. How many of you have studied health communication in school? 1, 2, 3. So a handful of you already have, so that's good. How many of you have studied health marketing and health promotion as well? So, okay, so you've heard these concepts. So for you, this will be nothing new. But for most of you, hopefully, it'll be something thought-provoking. And then I'm going to transition and talk about social media. I know everybody has experience with social media. I'm going to talk about it in a different way, though. I'm going to talk about social media as a data source. We could talk about it as a health communication tool as well, but it's kind of obvious as a health communication tool. It's not that obvious as a disease surveillance tool. And there's some exciting things happening right now around the world using this kind of passive data to learn about health burdens. So let's begin with this. The first thing I want to tell you about is I am the executive editor, meaning I do nothing at all, but my students actually do the work around this particular journal. It's called the Interdisciplinary Journal of Health Sciences. It's an open access, zero-fee journal run entirely by my students, and we accept submissions from everybody around the world in English or French. So if you have work, any kind of research or commentary papers, health-related in any way that is scholarly, and you're looking to get it published, we'd be happy to consider it. It's a peer-reviewed journal, so that means you send it to us like any other journal. We do some cursory editing, then we send it out to other scientists, usually professors at my university, to determine if it's worthy of publication. Then we send it back to you, you revise it, and then if it's accepted, we will publish it. So keep it as an option for you. There are lots of journals, wonderful journals in India as well, but I introduced you to our journal as well, and again, we'd be happy to hear from you if you have stuff you want to publish. And for your careers, I highly advise that you start seeking publication opportunities as early as possible. So again, these slides are on my website. You know what that is, it's mylastname.com. Click on academia, scroll down to IITGN, and this will be there. All right, any questions about the journal before I go on? Good. Hopefully I'll get some submissions from you later on in the year. We publish 1 or 2 issues per year, usually 1, because we're slow. Okay. Let's start. What is health communication? This is the Wikipedia definition. It's the study and practice of communicating promotional health information, such as public health campaigns, health education, communication between a doctor and a patient even is health communication, all with the goal of to influence personal health choices. I think the choice aspect is the critical thing here, is ultimately we're trying to encourage some kind of behavior change. Now, there's some danger there, because once we are encouraging change of a certain nature, the assumption is that we know what is right for you to do. So again, there's an element of paternalism here that we always have to keep aware of. And very quickly, in my opinion, public health can become a little tyrannical when we start thinking we know better than everybody else. I like to think about health communication as an exercise in empowering people with information such that they can then make sober, objective choices. But as you know from things we've learned this past week, there is no such thing as objective choices. Everything is tainted with an agenda and a bias.
Can we call it informed health choices?
Informed health choices. We could call it that. We could certainly, that's what they would like you to call it, you know, the professionals. I'd like you to keep in mind, though, there's always going to be a little bit of political bias here, in that I know what's best for you. I know you shouldn't smoke. I know you shouldn't eat salty foods. I know you should get lots of sleep. I know you should drink water. Maybe you know these things too, but you think it's more important for you to be with your friends. You think it's more important for you to eat bad food because it encourages your relationships. I'm off on a tangent though. You see where I'm getting at though. This is a complicated field if you go deeply into it. So what can it be? What can health communication be? It can be a media campaign for the public. That's very common. Again, I'm taking the big view here. What Mukta described was a small community intervention and research project where she's engaging with people, or her friend is engaging with people, to gain trust and information, and then to have an initiative. It can be a conversation between who? Between anybody. It could be, usually it's between a representative of the state, a doctor, for example, and a citizen, a patient. But it could be between you two people. Maybe you have a friend who smokes too much and you want to have a friend to perhaps consider not smoking as much. That conversation you have is an exercise in health communication. Very often, it's an initiative to engage policymakers. So as your careers unfold, you may be called upon to write a brief, to present to a politician, to say, this is what's important. According to our data, you should be doing this. So the way that you approach them is an exercise in health communication. Instructions on a drug bottle. You take your bottle of paracetamol or something. It says to take 2 every day, 2 times a day after meals or whatever it says. That's an exercise in health communication. You have to understand the audience, choose the right words, and you must have in your head the outcome that you want. In this case, it's appropriate behavior when it comes to drug use. A warning label. Do cigarettes in India, do they say this will kill you? What does it say? Anyone know? You know that too well. You're all smokers, aren't you? All right, so you know that, yeah, we have warning labels. These are exercises in health communication. So the history of smoking is, in fact, anti-smoking campaigns is a wonderful little example looking at the evolution of health communication. It started out on the packages saying, maybe you shouldn't do this, right? Then it became pregnant women should really be careful about smoking. Then it became smoking will give you lung cancer. And now in Australia, they have pictures of actually decaying lungs on the packages. In Canada now, we have a movement towards having nothing on them whatsoever. You can't put anything on the cigarette packages. You start to wonder now, why not just ban the cigarettes? You've gone this far. But that's another story, right? So all of those are exercises in health communication. Did I tell you the story already? I don't remember if I told you the story of the wells. Have I? No, I haven't. This is a well, I think it's in Rajasthan somewhere. So it's a series of wells in an area where people are not very literate. And some wells have bad water, have contaminated water, and some wells have good water. And there's no way for the people who live in the region, who are nomadic, to know which wells are good, which ones are bad. You can put a sign up, but often they're illiterate and they can't read the sign. So an NGO had the brilliant idea of painting the outsides of the wells. So the bad wells were red and the good wells were green. Is that health communication? Yes, it is, right? It's right. It's indirect. It's actually pretty direct, in my opinion. It's symbolic health communication. There's no words used. There's no language, but there's obviously a message being sent. And then you spread the word that red is bad and green is good. Usually I give this as an example in my ethics class because this actually ended up doing some bad things in this community. Can you guess what the bad things ended up being? Because remember I said in the ethics lecture that what is bad is something bad happened as a result of this. Remember I said that technological interventions usually lead to social problems? Painting a well is a technological intervention. The social problem it led to was that it became a caste almost. We had green well people or red well people. So the matrimonial ads were green well family seeks green well son for the green well daughter. So we created some problems. Not we, but the NGO. But that's a tangent. The point is this is an exercise in health communication. It isn't always a conversation. Sometimes it's symbolic. So I got this list from Unite for Sight, which is a global health organization at Yale University. And they suggest that effective health communication has these characteristics. It's got to be accurate, that's obvious. You know, it has to be targeted, it can't be too vague. It has to be accessible to the people that need it. I won't go through all of these things, but the important ones here that I want to point out to you is evidence-based. A lot of health communication very often isn't evidence-based. And I'm going to give you an example of a problematic one in a moment. A couple of problematic ones. See if you can see the problems. They like repetition. So keep repeating the message over and over again so people understand it. And this one I think will resonate with you, cultural competence. Okay? So is the language, for example, appropriate for the target audience? Am I using too big words for my audience that perhaps is illiterate or that speaks a different language from me? All these things are important. Okay. What are the barriers, do you think, to good health communication? What prevents you from getting the message across? Shout out some examples to me. Sorry? Cultural, absolutely. Culture is a big one. What else? So I hear you. Language differences? Absolutely. Two big ones. Those are probably the two biggest ones. What else?
Complicated words.
Complicated words, yeah. All these things are true. Let's see what I've got here. Stigma. Oh, yeah, stigma's a good one. Literacy is the obvious one. Literacy includes language and culture. The education level of a target population. If I talk about, this will cause a blemish on the alveoli of your lungs if you smoke, who knows what I'm talking about? Yeah? So if I say, if you smoke, you're going to die, that's a bit more compelling. Poor human resources. What this is maybe the people I have going out giving the health communication messaging, maybe they're not the best trained for this. If I just recruit some random volunteers to give a complicated, important message, I'm not going to get the best effectiveness out of them. So, several people in the literature point to a poor internet as being a barrier to health promotion, because more and more being connected via the internet is the avenue of choice for much health communication messaging. And when we talk about social media, this will be a bit more clear. But consider that a problem. So places in India in particular where the internet hasn't penetrated yet rely upon an older form of health communication, one without the advantages that we have today with more complicated methods. So here's the example I want to show you. This is a photograph that I took in a subway station in Toronto. And you probably can't see it, so I'll read it out. It's an ad put out by the Canadian Foundation for AIDS Research, HIV/AIDS, called CANFAR. And it says, it's 3 sentences. It says, did you know that 86% of HIV-positive Canadians are male? Second sentence, 2/3 of boys aged 15 to 19 are sexually active. Third sentence, you think your kids aren't at risk? Think again. All right, what is this ad trying to say? What's the message here? Boil down to a couple of words, 3 or 4 words.
Educate your children about the dangers of having unprotected or unsafe sex.
Okay, that's probably it, because what will happen otherwise? What's the risk otherwise?
They get infected.
With HIV/AIDS, all right? So they're saying that young males are having sex and they're getting AIDS. That's what they're saying. Do you see the problem with this ad? It's gender biased, sure, but it's targeted boys anyway. So, and by the way, you should know something about Canada. HIV in Canada is almost universally a male phenomenon. Okay? That's something you're probably not aware of. Of course, the women have it too, but it's almost entirely, that statistic is true, right?
It doesn't talk about girls.
Doesn't talk about girls, that's true, but the target here is boys. There's something else wrong here.
Focus is, you think your kids aren't at risk. Focus is on parents to educate them.
That's true. That's actually a good thing. They've targeted the right audience here. They're saying,
I think it doesn't talk about what to do.
doesn't talk about
It doesn't talk about what the cure is.
what are you going to do about it? So really, what's the purpose of this? You haven't got the answer yet, but this will become clear. What I want you now to think about is these 3 sentences, are they rational? Do they make sense? Do they belong together? The answer is no. They do not make sense. They do not belong together, and I'll show you why. They're selected very strategically to tell a tale with an emotional, political impact. But I would say this is a problematic ad, and we'll go through this in a second. We agree, though, that the message here is that boys in Canada are having sex and they're at risk for HIV. That's a big problem, right? That's what the message is. We agree, right? Because we have big numbers here, 86%, 2/3. These are big numbers. But let's break them down. 86% of HIV-positive Canadians are male. What's the dominator? It's actually, there's a lot of Canadians, a lot of male Canadians. It's huge, right? 58,000 people are living with HIV. That's not a lot. It's not a lot. It's a very small number. It's 86% of this number. It's not 86% of all Canadians. So automatically, our number has dropped dramatically from 15 million Canadian men to 58,000 Canadian men. It's gone down. So that means 49,000 males living with HIV. It's male, not men. So that combines boys and men. Meanwhile, youth between the ages of 15 and 19 are only 1.5% of all the cases we know of. But they chose that word specifically to be able to conflate these 2 groups, right? Even though the youth don't account for a lot of numbers. I'm going to jump ahead and to say that actually the risk of a young male having sex and getting HIV is 0.1%. It's vanishingly small when you do the math, and they know that. So I ask you again, what was the rationale for that poster then? We assumed the rationale for the poster was to say that young men having sex are at risk of getting AIDS. The truth is, young men having sex in Canada are at minimal risk of getting AIDS. So what is the true purpose of that ad, do you think? I'm so cynical today. I'm sorry?
The message in the ad doesn't reflect what action the reader should take.
Well, because it doesn't care about what action the reader should take. So I'm getting at, the real purpose of the ad is to justify the funding of the organization. In this particular case. So this is a long tangent to go on to show that very often health communication is not about behavior change, sometimes about justifying the existence of an organization. And we have to be able to perceive that difference. And they're very careful not to have an action-oriented aspect to that ad. Okay. Now this is my opinion, obviously. I'm pretty confident my opinion is correct because the math is solid. 0.1% risk is vanishingly small. But they chose 86% as the scary number. So is that a good example of health communication? Depends on what you think good is. It wasn't a good example of health communication if your idea of good is to create positive behavioral change amongst people. Because as you all pointed out, it doesn't say what you have to do about it. It's just justifying the existence of CanFAR to justify their funding from the government. But it is a good example of health communication if you think that these organizations should be doing things to show that look, we're out here, we exist. This is why your tax money comes to us. I'm being very cynical, but I think it's important that we understand that these are genuine forces in health and development right now. That perhaps
speak from some moral standards.
there's some paternalism here too, right? And in my opinion, I think you're saying the same thing. In my opinion, a lot of this is around punishing sex. There's a lot of moralism here, which is one of my pet peeves, is moralism in public health, and it manifests a lot in health messaging. This is another one that's kind of similar. Let's see if you can see the issue here. Well, I think I scared Dr. Savanta away. This is an ad about domestic abuse. It's also in Canada. And it says, approximately 3 to 5 children in every Canadian classroom have seen their mother being assaulted. The second question, 70% of men in court-ordered treatment for domestic violence witnessed it as a child. Okay, what do you think this ad is saying?
It's the same ad.
Sorry?
It's the same ad as the previous ad. It's focusing on numbers.
So we got numbers, but what's the message of this one? Yeah, you're right. It is the same agency, and they're doing the same thing.
The asking prevalence of domestic.
They're saying it's prevalence, and also that we should focus on stopping it early on, because there's a generational effect happening here, which might be true. I don't know if it's true or not. I don't specialize in this field, right? And we all agree domestic violence is bad, it needs to be stopped. But hopefully now you can see that these numbers don't tell the full story. First of all, 3 to 5 children in every classroom. Is that a lot? I don't know. How big are the classroom? Are there 20 people, 100 people, 200? I don't know. Probably around 30 or 40. Obviously, 1 is too many, right? We can agree there. But that doesn't tell the whole story. I don't know how to feel about this. Second, 70% of men in a court-ordered treatment witnessed it as a child. That's an emotional kind of number. How many people who witnessed it as a child are not in a court-ordered treatment center is a question you should be asking. Or how many people in court-ordered treatment did not witness as a child? So this is half of the story. It doesn't allow you to compute an odds ratio or a relative risk. Those of you in epidemiology know what I'm talking about. So given we don't know the denominator, the other half of the story, this is a misleading statistic. I'm not saying it's not important. Of course it is. It's just they've chosen these numbers specifically to tell an emotional story that might not be the truth of the matter in terms of how important this issue is overall. Right? So, in this case, would you say that the intent here is to let me back up for a second. Is it okay to make choices like this, to present certain numbers, if your intent is to do good? They haven't told the full story. Just like in the previous one, they didn't tell the full story. 0.1% of boys if having sex are going to have AIDS. That's not a lot. But their intent is to have 0 boys getting AIDS. That intent is good. Does the end justify the means, is what I'm asking, in your opinion? I don't want an answer. I want you to think about it. Because when you discuss this with your friends, you will see that different people have different ideas. Do you have a comment?
Projecting the numbers wrongly will definitely send out wrong negative messages to society.
I tend to agree. My point of view is that public health professionals should be as honest and transparent as possible, because the second that the public gets a sense that you're deceiving them, the game is over forever. They'll never trust you about anything ever again. That's my personal opinion. When I discuss this with professionals, they tend to disagree with me. They say that it's okay to be a little bit deceptive because everyone understands that you're being a little deceptive if the outcome is a positive change. So that's a value judgment.
So for media, it's a dilemma because they want to attract attention. In the first glance,
Exactly.
they want
Precisely.
to pick up the magazine and read.
Right. So and this leads me to the next topic, which is that these are put together by marketing people. There's a strong relationship between business marketing and health communication. Much of the principles we have around health communication derive from the business world. So in business, their first impulse is, what's the outcome we want? We want to convince people this is important. We don't care how we get there. Kind of like we want to sell Coke. We don't care how we get there. So let's talk about that for a second. So that takes us to health marketing. That's what we're talking about here. Marketing a health idea. And there's a whole bunch of tools associated with marketing that cut from the cutthroat world of business, because business is all about selling your product. So health marketing is when you create communication and health information using the customer-based approaches that business has mastered so well. Right? So marketing is our process by which products are used to meet human or social needs. That's the official definition. What's a social need? Do you really need 8 pairs of shoes? No, you don't. But marketers will convince you that you do. So it's not really about meeting social needs as much as meeting the seller's needs, right? Sometimes. But we use their technology, their intellect, their approaches to sell ideas. So let's talk about what they call the marketing mix 4 Ps. These slides, by the way, are from the CDC, the Centers for Disease Control. Give them credit. The 4 Ps are product, price, place, and promotion. Product is what you're trying to sell. Price is what it costs. Place is how and where you're going to sell them, the channels, not necessarily a geographical place, but the avenues that they're going to sell it. And promotion is how you're going to communicate, the technology used to communicate it. So give me an example. Let's look at the product world. Let's say Coca-Cola is going to launch a new soft drink called Thumbs Down. Thumbs Down Cola. So what's the product in Thumbs Down Cola? It's the cola itself, right? It's the new drink. What's the price? That's how much you're going to pay for it. 10 rupees probably, the small one. Place, well, you're going to sell it at the corner markets and in the canteen downstairs and Shed 1. That's the places. We're going to start on university campuses. And promotion, how are we going to promote Thumbs Down? Give me some examples. Because you've seen cola being sold. Sorry, I didn't hear you. Celebrities. So on TV or on print ads, or maybe write a song about these things. Songs are good. I remember I was involved in a campaign in Guyana around deck salt for filariasis. Heard of filariasis? Filariasis is a mosquito-driven disease that infects you and your body parts expand. It's horrible. And one of the ways to prevent filariasis is a chemical called DEC. So in Guyana, we had created a product where table salt is mixed with DEC. It's a little more expensive, but you cook with it and you eat it all the time, and you are now immune to filariasis. So to get people to use DEC salt, we use marketing techniques. And we actually had a jingle, a song by this reggae band. I'm not going to sing it for you. It's in my head right now. No, I'm not going to sing it. So it's all about using DEC salt, and we had an ad on the TV, everyone's going to buy and use DEC. So we made it sexy. We made it acceptable. We removed the stigma of getting filariasis because all the cool people were buying DEC salt from the grocery store and using it. So that's the promotional aspect. So again, here's a commercial example. We have a soft drink company with a new cola, Thumbs Down Cola, right? New soft drink. Price, reduced price, introductory period. So maybe instead of 10 rupees, we offer it for 8 rupees. So everyone will start being excited by it. And they'll start discovering it instead of drinking Sprite and thumbs up. Okay? Thumbs up, sorry. Place. So we're going to give it to convenient locations. As we said, the canteen here. And promotion. Local paper, song, whatever it might be. Give me an example now of how we can use this same strategy in a health promotion context. Let's say we're promoting, well, the example I'm going to give you in the next slide, we're promoting a new HIV testing kit around the world. Because we're an NGO with clients around the world, governments around the world. How am I going to market this HIV testing kit?
It has to be affordable.
Has to be affordable, okay. Low price. Most NGOs, though, give things away. Price isn't always about money. Sometimes it's about time, opportunity, that sort of thing. So maybe we're going to say, this won't cost you a lot of time to use. This will not take a lot of effort resources out of your day. Place, well, we're going to send it out to all our clientele, and we're going to advertise it in a variety of ways. Let's see what I have here. So NGO develops a rapid HIV testing kit, provides results in half the time of the current ones, and so forth. Okay? Product, new HIV testing kit. The price, it's free for everyone to use. First. Place, where we're going to send it out to all of the places, all the local health departments that use HIV testing, and we're going to use it in national media and so forth. Okay? The difference, as I mentioned, between commercial marketing and health marketing is the payment. That's one of the big differences. I mentioned in commercial marketing, we talk about money. In health marketing, it can be about time. So one way to think about this is the consumer is asking himself or herself, what will it cost me to get this thing? Let's say we are marketing blood pressure testing. And we're telling people you have to go to the local drugstore or to the local university or the local hospital and have your blood pressure tested so you can know if your blood pressure is high or not. Okay? If it was a banana, we say it's 10 rupees, that's the price. Can I afford this 10 rupee banana? Now it's blood pressure testing. Can I afford 2 hours of my life to go down the street and get tested? So you have to minimize the price to make sure it's attractive to the people. You have to make sure the time is small enough so it's not a barrier to getting access to this health product. Sometimes the price isn't time. Sometimes it's social exposure. So if it's people being tested for HIV, that's a social exposure that I'm at risk for HIV. Okay? So how do I minimize that risk? Well, we'll do it at nighttime. We'll do it in an unmarked car that'll come by to your neighborhood. Or we'll pretend that we're testing you for something else. These are ways to minimize the social price. Right?
For example, in the introductory period, it can be part of the research project.
That's,
Then it can be door-to-door data collection, and as well as you are giving them information on their blood pressure and HIV.
yeah, that's a very, very strategic and creative way of doing it. That's true. Our goal, though, ultimately, is to have this sustainable. So we have introductory periods, we have research projects. Ultimately, for most of these health products, we want them to have a permanent or a sustainable presence in the community. There are all kinds of ways of abusing health marketing, health promotion. I'll give you a throwaway example of when they killed Osama bin Laden. When the American SEAL team went to kill bin Laden, they sent in a fake health promotion team to start hepatitis vaccine campaign. And they had all the children from the neighborhood coming in to get the vaccine. I think it was hepatitis. And that was a way for them to get DNA samples to compare it to the bin Laden family to see if he was in Abbottabad, Pakistan. Right? So that lost public health a lot of credibility in communities. Right? So that's a bad way of communication, obviously. Okay, target markets. It's important to recognize who your market is. The same way if I'm selling thumbs down cola, I need to know, am I marketing it to university students? Am I marketing it to taxi drivers? Who am I marketing it to? The same with health products. So does an old person value his assets more or less than a young person? Can an old retired person afford a 10 rupee banana more or less than a 16-year-old? Can an old person afford 2 hours of his day more or less than a young person? Right? So the way you measure cost will determine the target as well. Right? Or culturally, does an Indian value the product more than would a Kenyan? One size and not fit all. The campaigns have to be tailored. I love this story. Okay, so I was consulting to an agency in Delhi. This was like 20 years ago, the Naz Foundation in Delhi. And they had started handing out condoms to slum dwellers in Delhi. And mostly amongst truly uneducated, illiterate individuals. And they were trying to stem the tide of HIV/AIDS by encouraging safe sex. And the condoms had that picture on it, or a similar picture of a man and a woman engaged in intimate activities. And that would somehow communicate this is what the condom is for. When you're going to be intimate with your man or your woman, use this condom. This was a very bad campaign. Can you imagine why? What do you think resulted from this in one particular area? Maybe you've heard the story, I don't know. The condoms were not used appropriately. In fact, they weren't used at all. This sent a different kind of message. The message a lot of people saw was, we use this to prevent HIV. This is how you get HIV. Therefore, we don't want to have sex with women. They have HIV. We will have sex with men instead. So it actually started a little bit of an increase in men having sex with men in these areas because the messaging here told them that was safer than this, when in fact it is quite the opposite. So men having unprotected sex with men was seen to be safer than men having protected sex with women. Isn't that crazy? And that's a result of bad marketing and not having an appropriate messaging and understanding your target audience.
So I think, I don't know whether your numbers are familiar, because especially in rural areas where they do not have access to English, so this almost became like a Playboy magazine for many people.
There it is, yeah.
So the images were evocative, or the cultural whatever.
Mind you, that's almost a plus though, because it guarantees distribution, just not appropriate use.
Right, the use is on narrative.
Yes.
Yeah.
So there's a balancing act there. On the one hand, you want maybe a little bit lasciviousness to guarantee interest. So that's a spectrum that's rarely gotten correct. So here's another example of where marketing campaigns have kind of done good but bad at the same time. Right now, India has a non-smoking campaign going on. I think you have some laws evolving. The way it's evolved in other countries is interesting. So in North America and in Australia, no smoking signs like this were popping up all over university campuses. And then after that, all over the cities in general. Who can read that sign? What kind of people can read this sign? And the sign also had things like, if you smoke, you're going to get lung cancer, and 86% of smokers have lung cancer, 64% of all lung cancer patients were smokers in the past. Who understands that language? Educated people understand that language. Literate people understand that language. It worked on them. They stopped smoking. So a generation later, the smoking rates amongst literate people is down to almost zero in those countries. But the smoking rates among non-literate people, non-educated, is higher than ever. Because this, in fact, was only absorbable, only accessible and digestible by educated people. It created a divide between those who are wealthy and those who are poor. There's already a divide, now there's a health divide. The poor are now much more likely to have lung cancer than the rich. And it's never recovered. That's still the case in North America. The working class, the lower socioeconomic status, is much more likely to smoke than the higher socioeconomic status. And we think this was a big part of it. So when you're thinking about the smoking campaign in India, think about these issues. I have no solutions here, but it'd be interesting to see, because the no smoking campaign is relatively new here, in a generation, to see what the effects are. To see if in fact the messaging has been targeted to all groups equally, and to see whether or not there's been a differential that's been manifested in some way. Okay, I'm going to transition now to talk about social media. Before I do, any questions about the marketing, the health communication? Yes, sir.
How do you assess the success of a health campaign?
Okay, we're back to indicators there. How do we assess the effectiveness of anything? We must devise the indicators beforehand. And there are certain kinds of indicators that we care about. There's outcome, output, and throughput. And you hear those terms before, I assume. So in general, the output is how many people saw the campaign, how many people participated in the campaign. The outcome, on the other hand, is what we care about. The outcome is, did the rate of the disease or the outcome we care about, did it change?
if the indicators haven't changed, that means the campaign is failed.
Probably, if you've chosen the indicators correctly.
Because in India, I find smoking campaign is going on TVs everywhere.
Yeah.
But the cigarette consumption is actually increasing. The
Right.
cigarette market is increasing.
Right. Yeah, so
That means the campaign has failed.
possibly. It depends on, was the correct indicator chosen and was it measured correctly? So there are all kinds of issues there. How are you collecting that data and which is the outcome measure you care about, right? So again, with smoking is interesting because smoking, you're right, education campaign in and of itself is often insufficient. You need other interventions like taxation. You make it more expensive, suddenly you can't afford it. Now that's interesting because if it's more expensive, only the rich can afford it. So the poor definitely can't access it, and the rich can. So now the differential of a disease changes, right? Or you create a stigma associated with it. Right? So these health campaigns in and of themselves are rarely effective alone. You bring a good point though. I would say that every social marketing health campaign must have an evaluation component with a timeline associated with it. Right? So very often they do not. And for things like smoking, what is the timeline? I don't know. There's no way to know. How long should it take to stop smoking? How long does education need in order to overcome years of addictive behavior? We don't know. So these are things that confound our ability to measure outcome. Good question though. Evaluation is key to all this.
So with the no smoking act, even if we remove the words, let us say we are writing it, the image which was shown, when you say that among the illiterate, the smoking rates actually rise, like maybe because of the colors they use.
Could be.
The red color actually grabs attention.
It absolutely could be.
We could see that the cigarette.
All these things are possible, and we don't know unless we investigate. Right? So that's why it's such a complicated game. Yes?
So how to test whether the non-textual component of the advertisement is effective?
You could set up a variety of test parameters. You could have a quasi-experimental design, which is what they usually use for these things. A quasi-experiment would be in one community you use the non-text, in another community you use the text ones, and you see what the changes
No,
are.
I meant was whether when you're using a picture
Yeah.
to convey some message, whether that picture is really conveying the message.
Right. So a validation exercise. So you again, a proper campaign would include a pre-exercise in validating the instrument. That's kind of the assumption here. I assume it, but very often doesn't happen. Very often validation does not happen. And by validation, I mean what she says. I mean we have to make sure that what we think we're doing is in fact what we're doing. Okay? If, the way we perceive this image may not be the way others perceive this image. So we have to make sure we test that in a sample first. Okay, so let's talk about social media. We all know what social media is. We know what these symbols are, right? What's that? Facebook, what's that? What's that? Okay, you all know that, good. Most of my students don't even know what that is. They know those two, so that's good. I know some of you have added me already. You're all welcome to add me, that's fine. And some of you have added me on Facebook. I will say yes once the institute is over. So in 2 weeks I will say yes. Until then, I'll put you on hold. So I put these symbols up there because these are the most popular ones, but rest assured, in 5 years, there'll be new ones. There'll be different ones. They will look entirely different. The technology is always shifting. In India, you had Orkut a while back ago, right? Orkut was quite popular here. Orkut's dead now. Nobody cares.
WhatsApp is getting popular.
Is it? WhatsApp? Well, yeah.
It's even Pinterest.
Pinterest, but Pinterest will be gone in 5 years. Viber was big here for a while as a communication platform. Now WhatsApp has replaced Viber usually. So the point is, the technology will change, but the fundamental principles will not. I'm going to transition now from talking about social media as a communication tool, I think we all understand how that works, to as a data collection device. Before I do, I will say this. The same principles around social marketing apply to social media. For example, if I'm going to use a Twitter campaign to change smoking behavior, who am I going to reach? I'm going to reach people with Twitter accounts. Who are people with Twitter accounts? They're people with phones or computers. They're high income. They're people who are educated enough to understand Twitter. People who speak English because Twitter doesn't work with other languages that well. Suddenly your population has come down to a very specific subpopulation. So this is not really ready yet as a social marketing tool platform for a country as diverse and as large as India, in my opinion. It will one day soon. Okay, with that being said, social media, we can define it as whatever, websites, applications, they enable us to connect, to network. And if Dr. Srinivasan was here, he'd be talking about social network analysis, which is fascinating. And the idea there is we figure out who in your social network is the most influential. I have 1,100 Facebook friends. That's a lot, right? And so my colleagues use me to reach other people because I'm considered to be an important node in their network. So if they want to advertise, they have a new book out or a new opportunity for students, they will have me put it on my Facebook page and I will broadcast it. So one of the important things in network analysis is identifying the people in the network who create the most amount of change. So you know, when it comes time to start your campaign, you target those individuals and you save money. There's no need to target everyone. I'll just target the 20 people I know who have over 1,000 Facebook friends, and they'll do the rest. Okay, so that's part of the network analysis there. Okay, what is this? Oh, sorry, yes?
How do you do that?
Okay, there's a whole science there. So the network analysis is a statistical technique where we look at visually the mapping of how people are connected and see who has the most nodes. So maybe we can talk about that in a couple of weeks when we do the methodology segments.
It's sociometry where, you know,
Yeah,
you have all the connections, they form nodes. And
that's exactly the same thing. It's exactly the same thing. So let's segue now to disease surveillance. Who wants to define disease surveillance for me? You know you've heard that term before, right? Yes, maybe, I hope? No? Never?
active surveillance of the status of the disease.
Take the word active out. And yes, that is correct. So it's an information-based activity that involves the collection of data about the nature and the distribution of disease such that we can do health planning and allocation of resources. Those are the kickers here, is we collect information about disease so that we know where it is, who it's affecting, when it's affecting them, and what it's costing. Costing in terms of money or resources. Because without surveillance, we don't know how many measles vaccines we need. We don't know how many nurses we got to hire. We don't know how many trucks we have to buy to send those nurses to whichever in order to give away the inoculations. Without surveillance, we know nothing, and health promotion stops. So disease surveillance is critical, and not everyone does it well. It's hard to do. So there's a difference between passive and active surveillance. Does anyone know the difference? Active and passive surveillance? I mentioned it last time. What is it again?
When you go and collect the data, that's active, and the data comes.
Eight. That's exactly right. So active is when I go out and get it, and passive when it comes to me. Now there are pluses and minuses. With active, because I'm getting it, it's probably accurate because I know what I'm looking for. It's probably complete because I can go and get everyone, you know? But it's expensive. It's expensive for me to send my employees out to measure, to take blood samples of everyone to see who's got what disease, and to take everyone's blood pressure to see what the prevalence of hypertension is. Passive is when it comes to me. Now, passive can come in many different ways. Sometimes it's through a notifiable registry where doctors know that if they see Ebola, they must call me, I'm the government, and tell me. Or sometimes there are systems in place that troll through data, like hospital data, and say, oh, this person was admitted and they had high fever and they were sweating and losing a lot of weight. I bet they had Ebola. And that triggers a response, and that gets sent to me also. All that is passive. The thing about passive is cheaper, but sometimes it doesn't happen promptly. It takes time for it to come to me. And also, I don't get everything. Sometimes those doctors who got the Ebola patient says, I don't have time to call Dr. Deonandan, I've got work to do. So it's incomplete. And sometimes they'll say, oh, I've got an Ebola case here. And it's not really an Ebola case. I can't tell because I'm trusting him. So there's a difference in the two, okay? So we like to have both. What I'm suggesting to you is there may be an opportunity in the next few years to augment disease surveillance systems with social media data. Would this be active or passive surveillance if I'm using social media data? Passive. It would be passive because it's there. And I'm just going to look at it. Right? There it is. So the first example that changed the world was something called Google Flu Trends. Has anyone heard of Google Flu Trends? Google Flu Trends changed the world. and then changed it back again. And it introduced the idea of big data. Have you heard the term big data? Okay, good. You should know more about big data because big data is transforming epidemiology and demography and public health and everything. There's a lot of money being spent on big data, a lot of expectations of big data, and maybe too many expectations. So let me tell you the story of Google Flu Trend. Google Flu Trend was started by the Google company, where one day the programmer said, you know, 10 billion searches are done every few minutes on our global network. And we can tie those searches with geographical data because we know where it's happening, we know when it's happening, and we know the temperature of when it's happening, we know the political climate of when it's happening. We have all these other data we can link together. So much so that statistically we can ask it pretty much anything we want to know, and within a certain margin of error we can probably be pretty accurate. And they chose the flu to look at. Flu is influenza. Influenza doesn't happen a lot in India, but it happens a lot in North America and Europe and Central America. So what they decided to do was to look at any time someone typed in a search for anything resembling influenza, like cough, sputum, mucus, pain, fever. That triggered the computer to think, maybe this is the flu. And then they'd associate it with the time of the day and the time of the year. Oh, thank you so much. And other things. And the computer was smart enough to say, well, maybe that's a signal that this is a case of the flu right now. Now, with several billion searches happening all the time, they were able to draw a map. This is the definition by the Google Flu Trends, the web service. They looked at the web searches to see if the flu was happening. Now look at this. This is scary. So this is 2000 to 2011. So this is what the Google Flu Trends thought the incidence of the flu was, and this is the actual incidence. Pretty close. Pretty darn close. And this changed the world. People started thinking, we can use this for all kinds of things now. Google is producing so much data that we can ask it anything we want. Now here, it's almost identical, right? It's almost the same. It started getting different there. Do you know what happened here? Because here, Google underestimated the flu. Do you know what happened? Why did they underestimate it? There's no reason you should know, but that was when we had the swine flu epidemic in North America. And no one saw that coming. Therefore, nobody was Googling it. If no one's Googling it, Google doesn't know about it. Once they start Googling it, then Google knows about it. If it happened suddenly, Google didn't know, and so they underestimated it. Okay, not bad, not bad. So now they had more ideas of how to make it better. So they refined the algorithm, and they tried it again. Next couple of years, it got really good. Look at that, it's almost 2011. It's exactly the same. Remember, the red is the actual cases. The blue is Google's modeling of those cases based upon Google searches. At this point, we started thinking, we don't need surveillance anymore. Now Google can do it all for us. Social media, in other words, can do it all for us. Because a Google search is just social media. That's all it is. It's people typing things in and sharing with their friends. Right? But then something happened over here. Google overestimated. Before they underestimated. Now they overestimated it. This you can probably guess why. Why do you think they overestimated it? Think about how the data is generated, how it's collected. Okay, people are typing in their symptoms to figure out what they have. So a couple things are happening now. Not everyone has the flu. Some of them just have a bad cold or allergies or something. So that's the first thing. Second of all, what else? What else might trigger enormous web searches about something?
People looking for information though they don't have this.
That too, and what might they be looking for? It's a difficult thing to think about. Who's the biggest celebrity in India? Okay, well, Shah Rukh Khan, if he does something, what will happen the next day? Will people Google what he did? So let's say he decided to eat a banana backwards. So the next day, everyone is Googling Shah Rukh Khan and banana. Suddenly, Google's going crazy with banana searches. Crazy. And Google has an idea that, oh my God, everyone cares about bananas. That's got to be the most important thing in the world. No, it's because just Shah Rukh Khan ate a banana. That's the only reason. So suddenly, a couple of famous people got the flu. And so they search their names, and everyone cares about them, and so it goes off the grids. And the media started covering it. Now, people started finding out about Google flu trends here, and so people started writing about it. And because the media is writing about it, it appears more often in social media, and it overestimates it again. And then New York declared a public emergency about the flu. And because it's a public emergency, it became big news. And because it's big news, it appears in social media more. So suddenly, the power, the brilliance of using social media to gauge disease worked against itself. The better it got, the more inaccurate it got, because people started looking at it more. The more you look at it, the more inaccurate it gets, because it overestimates. And that might be the end of the story of Google flu trends, right? So
Might there be a rule of social media gossiping in this?
that's exactly what this is. That's exactly what this is. A better way of phrasing it. Right? So there's an old adage in data science. It's called garbage in, garbage out. That means no matter how good my statistics are, no matter how good my system is, if you give me bad data, I'm going to give you bad analysis. So if the garbage in is Shah Rukh Khan even eating a banana, or Tom Cruise has the flu, or people gossiping about the flu, that's garbage. The best I can give you is garbage. So this comes down to. So this was, Google claimed this in 2009. This was their big claim. We can accurately estimate the current level of weekly influenza activity in each region of the United States with a reporting lag of about 1 day. So they can predict within 1 day what the flu rates are going to be. But they're wrong. And we call that big data hubris. You know what the word hubris means? Have you heard that term? Hubris is a kind of arrogance. Right? So this is their arrogance, and they were wrong about it. Okay? So Google assumed a constant relationship between the flu searches and flu prevalence. It was not true. Now, we talk about the flu. You don't care about the flu. The flu doesn't affect most of the world. It only affects 5, 6, 7, 8 countries. But Google has expanded their service to look at things like dengue. This is Google dengue trends for India. You know this existed? I bet you didn't know this existed. Google is predicting the incidence and prevalence of dengue fever in India based upon your searches. Now, you notice I don't have the red line here. Remember, the red line is the actual cases. Why don't I have a red line? No surveillance, exactly right. So that's the kicker here, right? It's I said before that the social media estimation is diverging from the actual cases. We don't have the actual cases, so this is the best we can do. So in absence of good data, I would argue we should use this as some kind of guide and do our best to see if it's actually accurate. And by the way, what this shows is the incidence rates over the year. So they think that this year, projecting ahead, by October there'd be a lot more dengue cases. Okay.
Could also be a kind of a cultural argument here that people in the West are, there is a more paranoia about health and disease.
That's interesting. That's very interesting. I hadn't thought about that. Because you said earlier that here health is a low-risk asset, which I've written down. I'm going to put on a T-shirt one day.
Yeah, so there will be more searches. People are generally
Right.
how stuff works.
You're right. However, because there are so many more people here, the lower fraction of a large denominator still works out to be more data than we get in America. Right? So 100% of 300 million is still less than 25% of a billion. Right? So there's still plenty of data here. It may not be representative, but there's enough of it that the magic of big data kicks in. And it is a little magical. Now, I said the magic of big data because companies are lining up to use this technology to do all kinds of interesting things to make profit for the companies. So if you're looking to get out of health into something else, look into big data analysis. Your career is set. It requires statistical analysis. Now, I mentioned that India does not have actual dengue data, so I'm arguing that Google's dengue data may be the best that we can do because it's hard to get dengue data. There's a certain class of disease it's almost impossible to get prevalence data for in most countries. What am I talking about? What kinds of diseases am I talking about? Did I hear something?
Non-communicable.
It is a non-communicable disease, but more specific than that. A certain type of diseases. It's also the disease that the daily allows us to measure so well. I'm sorry? Accidents we have pretty good data around, actually, because accidents we have, police data for. That is correct. Mental health disorders. Right, there it is. There's the guy with the mental health, or a bad headache. I don't know. So why is it that we don't have good data for mental health disorders? That's the first. People don't realize that they're ill, so it's underdiagnosed. There isn't the same presentation. What else?
Even if they realize they don't come forward for the stigma.
So stigma. Stigma is a huge one. And how about from different countries, comparing them is difficult. Why? Would the definition of mental illness in this country be the same as in the USA, and the same in Trinidad, and the same in Nigeria? No, 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 no. Very different. So someone considered mentally ill in Canada most definitely would not be considered mentally ill here, because the standard of the bar is set much higher here. So it's almost impossible to get good surveillance around mental health issues. They're very culturally specific. So really, social media right now is our best bet for measuring the prevalence and distribution of mental health disorders. And I'll show you a couple of attempts. This one is called Mood of the Nation. And Mood of the Nation is active in several countries. This is the American version. What they do is they look at Twitter searches as opposed to Google searches. So people are saying, oh, I feel sad today. Oh, I don't feel like going to work today. Or look, oh, the sun is shining, I feel great, whatever it might be. So after several 100 million of those searches, they can associate it with the geotag in Twitter. The geotag tells us where it came from. And to create mapping clusters of where people are probably happy and where they're probably sad. So this is an attempt to measure depression, really. Right? So here we have the trend in the USA as a whole. I'm not showing you geographical data, just the USA as a whole. From 2012 to 2015, and it showed this is the people who are happy, this is the people who are sad. So people are getting less sad in the USA, it seems. People are getting more happy, according to Twitter. I don't know if that's accurate or not. How about other countries? This is the UK. So the UK, this is a more complicated graph, but it shows us that the green is joy, let me see, anger is down here, fear is over there, and this is from 2013, this is all 2013, so February to March. Okay. These are the I'm sorry? Oh, they are in the UK, yeah. I think when their soccer team loses, they get very angry. So is this accurate? Who knows? We have no standard to validate it against. But it's a start. The technology is not mature yet. This is where people are going right now, to use this kind of data. So if you're looking for an interesting project to do, this is all free. You can go to search.twitter.com and just enter search terms and see what comes up and analyze those data. We've done a similar thing, looking at prevalence of various things in Canada, just out of curiosity. But definitely this is an area of expansion in global health, using these free passive technologies to gain insights on the distribution of various diseases.
So can we use the number of searches for each term as a validation?
Yes, that is exactly what that's, well, this isn't number of searches, it's number of appearances, number of tweets. Number of searches we can't get on Twitter, they haven't got that.
So for Google they have that. So each term they have
Yes.
number of searches across the world.
Yes, they can. The problem with Google is Google's data is not freely accessible. So unless Google does it themselves, we don't have access to it. So Google does the flu and dengue thing themselves. So we have access to that. Twitter, on the other hand, Twitter is free for the most part. You can access that data and do it yourself. So who knows how it will look in the future. There are other examples. There are people mining Facebook and Pinterest and things like looking for similar things. So if you Google social media disease surveillance, you will find several, not hundreds, but maybe scores of attempts to mine these data to create this kind of insight. Is this a viable tool for disease surveillance in a developing country? Why not? Why don't you think so? I saw some head shaking.
More or less, yes.
You think yes? Okay, why do you say yes?
Because countries like India, where there is no other method of computing,
So it's better than nothing.
have something to act upon.
Right. Now, here's the danger.
Better than nothing.
What's the danger?
It's not accessible means large population are not accessing social media.
That's right, exactly. So it's a very specialized subsection of the population. We're assuming that that specialized subsection is representative of the whole. Probably isn't. Now, I tend to think like you do, that it's better than nothing. However, the risk here is that we spend our public health money incorrectly, and we've squandered our resources incorrectly. So I think there's a delicate balance here to be made. It's better than nothing, but it has to be at least a little good. Right? So I don't know where to draw that line. That's a challenge that decision makers have to make.
So really localized issues, and if we either over-reporting or under-reporting.
That's exactly right. Very intuitive of you. So it's actually very good for local issues, more so because there's less heterogeneity. One thing I want to point out is that the Google is probably better than Twitter for this, because there's less signal to noise. No, ever heard that term, signal to noise ratio? It's an engineering term. A lot of you are engineers, right? So Twitter has almost equal signal noise. There's a lot of nonsense happening there. With Google, because of the complicated search parameter, we can filter out a lot of the noise. That's why Google Flu Trends, for a while, was so accurate. Twitter, I don't know. That's the best we have. Is that my last slide? That's the last slide for this bit. So before I finish off today with medical tourism, any questions about social media health communication? Yes?
I want to know about your personal opinion. How education is like you mentioned things nowadays in life that education, because of education, you are not able to.
Okay. So let's say perhaps barrier is not the right word, but it's a factor to consider. So let's say you're doing an anti-smoking campaign, and you have all these materials with you. You go into a community and say, if you smoke, it's going to lay a deposit of tar on the alveoli of your lungs at the basal level. These are medical terms that only a well-educated person can understand. So,
in this case, if you talk with an educated person,
yeah.
so still they will understand.
Right. So the point I'm making is you must tailor-make your message to be appropriate to the education level of the audience. So if you're speaking to a medical person, you can use this language, they'll understand. If you're speaking to a non-medical person, you say, it'll give you cancer. Simple as that, right? So you cannot let their inability to access your medical knowledge be an impediment to understanding. Does that make sense to you? Really? So the education level of the audience matters. So let's say I'm talking to you. Right now I'm talking to you. Okay? I'm talking about things we all have expertise in, public health. I can switch. I have a background in physics. Let's talk about quantum physics for a while. Okay? We'll talk about, we do entanglement exercises. We take a upward spin quark. We disentangle it using a Bessel function. All these words mean nothing to you. Right? So suddenly, our education difference is an impediment to being understood. So I wouldn't use those words when talking to you about physics. I would use different words. So that's what I mean, where education level is an important factor to determine how well we understand each other.
But still, this is planning strategy problem, I think.
Yeah.
Which
Yes.
kind of planning you are doing?
Sure.
Which kind of tool?
Absolutely true.
Not still
Yeah.
agree with this.
We agree there. And I think you understand this intrinsically. A lot of people don't understand that intrinsically. I've seen many campaigns where people just roll out a textbook. They go into a poor community with a medical textbook and show them pictures. Right? And they haven't thought this through. That they can't read the textbook, what are you doing? Right? Unbelievable the problems people do or the mistakes they make. I've seen, in Guyana again, I've seen the CDC bring in the HIV strategy word for word from Uganda and just take the same books and the same and bring it in Guyana. Like, what are you doing? It's a different language. It's a different, what are you doing? So no one has, people do stupid things in the field. It's amazing what they do. Animation is great. Let's say your audience is blind. You can't use animation. So you just say, right? And if you're dealing with, let's say your intervention is hygiene for the extremely disabled elderly. So you have to use talking then, probably, not animation. But yes, animation is great. The takeaway from all this is you must tailor-make your messaging and your tools and your medium for the limitations of your audience. Right? Even right now, me talking to you, I have this ridiculous Canadian accent. I speak too fast. I use idioms that are specific to my culture. And maybe you're not getting all of what I'm saying, not because of any failure on your part, just because maybe I'm not the right person to deliver the message. So that, in some ways, is a poor health communication strategy on my part. Okay? So ideally, you want someone from that culture who speaks that language idiomatically, who understands the culture, who dresses the right way. All these things matter. Sometimes you want someone not from that culture. Sometimes you want an authority figure who we respected more to show up. Sometimes you want the angry old white man to show up and to be colonial and paternalistic. You know? I'll give you an example. Again, I'm from Guyana, South America, and we have a problem with our people who leave there coming to North America, and they get sick, and let's say they get too fat and they have to lose weight. And the doctors in Canada are very polite. They tell them, oh, perhaps it's time for you to examine your diet. And, and really what they want is someone paternalistic to say, you need to stop eating, lose weight, or you're going to die. So sometimes you need a difference in culture. Every situation is going to be different, depending on the outcome you're aiming for.
How effective do you think is the street plays for poor communities in terms of health?
Street plays are great. Again, not universally. Some communities I've been to around the world are anti-drama, anti-theater, but some love it. In the Caribbean, they love street theater. It's the best thing in the world. India, I've seen it do wonders as well, right? But I think China, I don't think it does very well, unless it's a kind of street theater that is part of that culture. But yeah, it's a wonderful thing, street theater. In general, I find those kinds of entertaining activities effective because, if I can go off on a tangent, the human brain, in my opinion, is wired to understand narrative. It's wired to understand storytelling. If you can wrap a message in a story, people get it more quickly than if you wrap a message in, here are the facts. If you say, Parvati was a young girl, and one day she found a cigarette by the creek, and she smoked it, and she liked it. And the next day she spent all the money on more cigarettes. And her mother was you tell this story about poor Parvati and how she got lung cancer because she found a cigarette one day. That has more impact than here's a picture of a lung that's got disease here. Yeah. And the different ways of giving narrative. I can tell you a story, or I can do a play, I can sing a song. Different ways of doing it. At the end of the day, all communication is storytelling. Boy, I can lecture, can't I? Any other questions?
So I'm guessing there's tea and samosa outside.
Oh, really? Okay, I'm sorry.
If you can come back.
Okay, we'll take one more. Yeah.
So the information actually leads to life in the intersection of the media. So they also what they using from the media. So is it a communication gap or?
Yeah, I think it's a communication gap. It's in India. You have so many barriers to getting this done because you've got caste, religion, literacy, language, gender, power dynamics, geography, physical barriers. All these things are so complicated, preventing it. You've got lack of access to infrastructure and to communication and to internet and all these things. So yeah, I agree.
Basically, last
Right. So are you saying specific castes are not confident in government messaging? I don't know if that's true, but if that's the case, then it shouldn't come from the government. It should come from an NGO or a trusted source. Okay? So there are ways around those trust issues. And usually the way is finding an ally who represents a friendly face. It can be a voice within the community. It can be another community that is not threatening, or it can be a foreigner. Sometimes a foreign NGO is the best way to go. Yeah? Let's get some tea. And we'll start this last half in 10 minutes. Sound good? All right.
join with you.
Sure.
What we